Hi, I'm Jennie Ketcham Crooks. I'm the founder of the West Coast Anxiety Clinic. And as a practice that specializes in anxiety and OCD treatment, we work closely with primary care providers throughout the greater Seattle area. And I know that referring a patient in for mental health care can be a really uncertain thing for a lot of primary care providers. And so today I'm sitting down with Dr. Adina Aldea, our clinical director, to have the conversation that I wish every primary care provider could have. It's going to help you understand a little bit more about the practical questions that come up when you're considering an anxiety referral, what happens after you refer, how can we partner together to give your patients the best care possible, and what can your patients expect in getting treatment with us. So Dr. Aldea has 20 plus years of experience treating anxiety disorders and training other clinicians to treat anxiety disorders, and she works directly with our referred patients every day. Dr. Aldea, thank you so much for being here, and let's just jump into some questions right now. Dr. Aldea, what are the specific signs that indicate when anxiety has moved beyond what primary care can manage effectively?
Usually it's based on the client's report. If the client comes back over and over indicating that, they feel distressed, they feel worried, they feel stressed out, they feel overwhelmed, they describe tendency to ruminate over things. And more than anything, all of these symptoms actually impact their daily functioning. They may impact their work, fulfilling fully work responsibility. It may affect their sleep patterns, difficulty falling asleep, difficulty staying asleep. It may affect the relationship with loved ones, with spouses, with children. Usually these are signs that, more help and support is needed in order to solve and work through whatever is going on with that person. And anxiety disorders tend to wax and wane over time. And sometimes people can have longer periods in which they feel fine, they function fine. And yet symptoms may reoccur and may reoccur in different forms, right? Maybe, 10 years ago, the person maybe had some fears about going out in public. And now they may reoccur as, what if I fail at work? What if I'm not successful? What if I'm not a good parent? A good sign of an anxiety disorder is this constant questioning, right? The what ifs, the never-ending what ifs, the never-ending worry, which leads to a lot of internal stress.
It sounds like there are a lot of symptoms that might show up on a PHQ-9 or a GAD-7, and that might be an initial indicator. But what I think you really pointing to is this idea that those symptoms start to impair their ability to function in their life more broadly. And I'm wondering, are there any questions that a primary care provider might ask a patient as they're seeing them to get a better sense of how that impairment actually looks in their daily life?
My experience with primary care providers has been that, they're pretty good at gauging when, the distress is there. If you as a primary care provider have a need to prescribe a medication and feel like that is necessary, then most likely than not, then therapy is necessary. The efficacy of medication is not as great. Medication alone is not as great as when it's paired with therapy, specifically evidence-based therapy to address specific anxiety disorders. If medication is under consideration, then maybe it's time for a referral as well. And we know from research studies that, issues like anxiety, depression, they are first diagnosed or caught on during primary care visits. So, primary care physicians play such a pivotal role in their clients' mental health, because they are the most likely to see it first. But it's difficult for a primary care provider to, in addition to managing their physical health, to have to manage this part. Chances of encountering patients with an anxiety disorder to be very, very, very high. According to the Anxiety and Depression Association of America, anxiety disorders ranked as the most common mental health problem out there. And in the United States alone, it is estimated that over 40 million adults suffer from an anxiety disorder. So high prevalence, and very likely these numbers have increased. The prevalence has increased after the recent pandemic. And the issue is that anxiety disorders are associated with significantly compromised quality of life and compromised psychosocial functioning. So the earlier the intervention, the better. When in doubt, even if you're not 100% sure, better to refer than not.
I have the pleasure of working pretty closely with a few primary care providers and have been over the duration of my career. And I used to work in a primary care setting, and as a social worker in that setting, also noticed the frequency of anxiety disorders coming through the clinic. And I think something that happened, and I would love for you to speak on this, is that I noticed, and a lot of the primary care providers in that setting noticed how anxiety would often mask other co-occurring disorders. So, Dr. Aldea, if you could, what should PCPs look for when anxiety might be masking or co-occurring with other mental health conditions?
Depression. And it can go both ways in the sense that the depression can be most prominent, and many times people with a severe underlying anxiety disorders tend to become depressed because the anxiety disorder becomes so impairing. People don't function, we become depressed. Depression stands out. We end up treating the depression, but we miss the anxiety. People are not likely to get better. Anxiety disorders come with poor sleep, insomnia, difficulty with concentration, with attention. Many times this may appear as ADD or ADHD, and actually can be an anxiety disorder, right? Stimulants tend to exacerbate anxiety disorder. So, a thorough assessment is very, very important. And this is when the referral is important to be able to differentiate. And many times they can co-occur just to make the picture a little bit more complicated.
I think that's really helpful. The note that if someone's coming into the clinic with depression, there is a pretty healthy chance that they're also coming in with some sort of anxiety disorder, and that we might be able to treat that depression with something like an SSRI. But if that anxiety disorder remains untreated, the impairments that show up as a result of the anxiety disorder will continue to increase the chances that they have this sort of relapsing depressive state. And I'm curious about specifically health anxiety and illness anxiety. And so what will that look like to a primary care provider? And when can they start to know that it might be time to stop looking for the sickness or the mysterious symptoms and time to refer? So if you could speak a little bit about health anxiety or illness anxiety in the context of primary care settings.
Sure. And I have noticed after the pandemic, quite an increase in health-related anxiety disorders, which makes sense. But nevertheless, these are the patients who always complain, always worry about their health, despite not finding any medical evidence. Or if there are some issues, they do not warrant the level of worry and anxiety that these patients exhibit. So what you're going to see, these patients tend to search and research the internet for symptoms. They assume the worst. Usually any pretty mild, moderate physiological reactions are interpreted as signs of severe illness that leads to death and dying with a lot of suffering in between. It's a fear of cancer, fear of heart attack, a fear of, losing one's memory, a fear of stroke. These tend to be the most common ones, but there can be some preoccupations with other issues. So it's this kind of like exaggerated response to an existing condition or even a potential condition. The actual symptoms, there is nothing to support diagnosis of an issue, a physical issue. However, the person worries excessively. So, we're going to see a lot of office visits, a lot of calls over and over. Many times these patients are diagnosed or seen as, personality disorder. They're just extremely anxious and they can become difficult to manage.
Do we see the opposite end of that as well, where a patient might be really avoidant of getting their health care or following through on orders, and that might also be wrapped in with the anxiety?
Absolutely. Avoidance is really, really a very common symptom of anxiety disorders, including health anxiety. And yes, it goes to the other extreme, right? This extreme fear of maybe taking a medication, following a course of treatment, even coming to check in when their visits are due, because they get so anxious they're going to get bad news and therefore they cannot handle it. They avoid even basic healthcare. I think this is harder to diagnose and catch than the first one, because the first one is more obvious and in your face. But whenever these patients do visit the doctor's office, some questions that are warranted would be, what gets in the way of you making your visits? Do you have a hard time following up with that? following up with us? How concerned are you about your health? Are you concerned to the point that you'd rather not hear any potential bad news?
That's a very helpful framework, knowing that the really high frequent flyers, there's a high probability that they're suffering with some sort of anxiety disorder, and those who sort of check in and then go away for a while, there's also a probability we could be looking at an anxiety disorder. Dr. Aldea, what information do you most need from a primary care provider in a referral to ensure that the patient gets the best care possible?
Not much, because I and we as a practice, we do a very thorough assessment of every person who comes in. So something as simple as I'm suspecting an anxiety disorder going on can be enough. We want to make it, I would like to make it as easy as possible on the referring provider, because I know how busy the primary care providers are. So I personally don't ask for much. Also, one of the things that I would like to know when the person is referred is whether they are on any benzodiazepines. And the reason for that is the use of benzos, especially long-term, can get in the way of recovery, can get in the way of the treatment that we provide. It decreases efficacy and also increases clients' anxiety sensitivity. So it's important to have that information. And of course, any information that the primary care provider deems to be relevant, what medications that are on, if there are any other, physical health conditions that may have an impact or not, anything they deem relevant for us to know, I think it's important.
So when someone is referring in, they have an option of booking directly with us on our website, or we can always do a warm handoff as well if someone is interested in a little bit more connection with one of us. And I'll make sure to provide our information in the notes below this video and in the email so that we can facilitate that warm handoff for you with ease. Dr. Aldea, what types of anxiety cases do you prefer to handle versus those that might need us to go to a psychiatric referral?
I've been in practice, specializing in anxiety disorders, my whole career, close to 20 years now. So anything that has anything to do with anxiety, I feel like it's in my ballpark to address, from agoraphobia to obsessive compulsive disorder, which is my subspecialty, to panic disorders, to social anxiety, to general anxiety disorder, along with the conditions or comorbid conditions. These may be accompanied by, depression, maybe some personality issues, substance abuse. Sometimes it's not uncommon. Any anxiety spectrum disorders. Even if a person's symptoms are severe enough to warrant a psychiatric referral, just medication alone tends to, again, as I said before, it's not as efficacious in an absence of therapy. And the reason for that is that if you do not make behavioral changes and develop effective coping to address the symptoms, the medication, due to habituation to respective medication, more dosages are going to be necessary. Increased dosage, changes in medications, again, decrease efficacy in the absence of therapy. And not any therapy. Unfortunately, anxiety disorders, unlike most mental disorders that respond to a range of, therapeutic interventions, anxiety disorders tend to respond to a specialized form of cognitive behavioral therapy. And unfortunately, it's not commonly provided. There is a lot of misconception out there among mental health providers as to what works with anxiety disorders. And the issue is these treatments and these interventions, in the good case, they don't work. And the worst part is that can make the symptoms worse. For example, like common interventions are to prescribe, relaxation strategy, mindfulness. People with high anxiety have a hard time engaging in these. And a person with OCD, for example, may turn those into mental compulsions. Yes, which would be quite detrimental and problematic. Again, the specialty treatment, really behavioral changes, in addition to cognitive changes, actually tend to be the most effective. Around 70-75% efficacy rates of these treatments, which is quite significant. And also, when well done, these gains tend to be maintained long-term, because people learn tools, learn skills, how to manage, versus reverting back to strategies that seem to be logical, like avoiding the stressor, avoiding the stimuli that creates anxiety, which actually further increases the symptoms and reinforces the symptoms.
And so what's really helpful about everyone that works at our clinic is that we are all trained in these cognitive behavioral therapies like exposure and response prevention, exposure therapy, prolonged exposure for PTSD. So everybody that comes into the clinic that works for us actually has at the foundation the ability to treat a variety of anxiety disorders in an evidence-based and efficacious way. So given that everybody at our clinic is able to do exposure and response prevention, and there are some myths about exposure and response prevention, I would love for you to talk a little bit more about that, about what it looks like in practice and what a primary care provider who's referring into us can expect their client to experience when they're doing this evidence-based effective treatment with us.
Common misconception about exposure and response prevention and exposure therapy in general is that it's horrible because, it makes people do all these things that they're afraid of doing. Now, that part is true about instead of avoiding, engaging and overcoming fear by putting to the test all of these intrusive thoughts and hypotheses of doom and gloom that people make. Now, when it's not done properly, it can be a pretty horrifying experience. That's why, working with well-trained providers with a lot of experience is very important. Also, many times what makes the treatment difficult for patients, and again, helps to spread this misconception that the treatment is so horrific, is that there is a mismatch between the client's presentation and, the exercises, the exposure, the practices that are being done. Many times, in an absence of extensive training, some clinicians may take one fits all approach. And this leads to, high distress because there is, again, a mismatch between what's going on with the client and what's being provided. It doesn't work. What we do is we provide treatment that's geared to address each person's individual concerns and presentation. Not two persons with the same anxiety disorder are going to have the same exact presentation. So definitely in terms of treatment, one size does not fit all. So we go about this in a stepwise manner, kind of like baby steps. And we get to know the person's specific presentation before we proceed with these exercises. We do thorough assessments. We develop what we call hierarchies, right? Not all anxiety is created equal. So we figure out what creates how much anxiety and procedures the treatment gradually, right? So ensure that the purpose of this is to ensure habituation. For example, like when a person or a kid is afraid of dogs, right? They're not going to overcome their fear of dogs by running away from dogs. They're going to overcome their fear of dogs by exposure to dogs or, being in the proximity of dogs, working with dogs, to dismiss, learn to dismiss through experience these practices. But we're not going to start with the biggest dog there is, ferocious dog. Maybe we'll start with cute little puppies or drawing, if it's a kid, drawing a dog and, having some contact with the tiny, cute little puppy and move on from there. We're going to jump in and, meet a German Shepherd. Things are not going to go very well and it is going to become a horrifying experience. And unfortunately, this myths and misconceptions and misunderstandings about ERP prevent people from seeking the treatment that they need.
And I would love to add on to that because I think another common misconception is that, especially for people who have OCD that has any sort of focus on homosexuality or any sort of like racial undertones, there is the misconception that the exposure will be to go out and do things that are racist or homophobic, but really targeted good treatment is also socially just. And so the creation of a treatment plan will not put a patient's values in jeopardy, and they will be values aligned, and good exposure will help a person live a more values aligned life through the exposure work.
Absolutely. And speaking of OCD, this is something that's really a subject that's really dear to me. And unfortunately, we don't have enough care and diagnosing of this issue. I don't know, if people know that a few years ago, the World Health Organization deemed OCD as one of the top 10 reasons for disability worldwide.
I didn't know that.
Yep. Yep, it's true, with functional impairment comparable to that of schizophrenia and bipolar disorder. And unfortunately, this condition is very rarely assessed. People are very unlikely to disclose it. Many times, these individuals are very put together. They look very put together, but they remain undiagnosed. And in addition to that, just to make things more difficult, OCD can take so many presentations, and some are so obscure, yet equally damaging to the individual suffering from it. Usually when people think about OCD, they think about germaphobes, people, who are neat freaks, but it's so much more out there, people who are over preoccupied with morality or religiosity, people who are like terrified of making a mistake, extreme perfectionism, over preoccupation with certain shapes or numbers or words, really hundreds of presentations. So it's very hard to catch. And many times, going back to a question earlier regarding the, screeners that are used in primary care, the PHQ-9 or 2 or the GAT-7 or 2, these are good screeners. They're not diagnosing tools, but also many times they do not fully catch or really screen people who suffer from this. So, a little bit of a clinical interview, asking questions as, what's happening, what's bothering you, what scares you, what is it that you spend time thinking about, how much time do you spend thinking about, these issues, tend to be more revealing to the person's inner workings and fears.
And I think the note about someone can look really well put together and still really be suffering with OCD. I know on my panel right now, I'm working with at least 5 perfectionists in the tech field, and there is a degree of reward and incentive to perform at the incredibly high level that they're performing. And there is also a degree of suffering that is resulting from continuing to meet that. And so I am so lucky that they all came through primary care referrals, but none of them came specifically for OCD or perfectionism. They all came because of work stress and feeling stressed in the workplace. So that might actually be an indicator that somebody is suffering with OCD or some sort of really impairing anxiety disorder if they are finding themselves in a work environment that is both really high stress and they're really sort of not managing that stress very well. So I think that's a really great note and something to be on the lookout for. Talk to me a little bit about how long you generally spend working with someone and what a PCP can expect when they refer someone in.
Well, research shows, right, and, research labs, research studies, the average number of sessions people need to see, some benefit is about, 12 to 16. Now, in real life, things are a little bit, more complicated sometimes because people may come in with other comorbidities, other stressors, life. Yes, we don't live in the lab, unfortunately. So the average would be 12 to 16 sessions. Some people need less, some people need more. There are quite a few variables that play an important role in recovery. One is the severity of symptoms and the degree of associated impairment. Another is motivation and readiness to fully engage in treatment. You kind of get out what you put in. The treatment involves a lot of work and practice. It's not, you come to therapy once a week and you talk about your day or the week and you move on. It requires a lot of practice in between sessions to develop that habituation, to develop these new coping strategies that actually work. In an absence of that, the progress is going to be inexistent or much slower. Other stressors that may come up, somebody can make great progress, but then, something happens, right? Because life happens, right? They go through a divorce or, the dog dies or something happens and, the treatment slows down a little bit. So it really varies widely from person to person. It's very hard to predict. But typically, this is, relatively speaking, short-term treatment. The treatment is highly effective. It's not the kind of treatment that people stay in for, 10 years or 3 years. really defeat the purpose. If you need to be in treatment for 10 years continuously, then, maybe it's time to find a different therapist.
That's helpful. I've worked with people for as short as that 12-week session where it has been foot on the gas. They came ready to work. They wanted to make the changes. They showed up. They did the practice. They did the practices between the practice that we do together in session, and they saw their life open pretty instantaneously. I have worked with other people for 3-4 years consecutively where they came in and we knew we would have to do exposure and response prevention at some point. But when they came in, they were in such a bad depressive episode that all of that needed to be treated. And that treatment took longer than anticipated just because it's so hard to treat depression, because when you're depressed, you don't want to do anything. And so I have worked on a longer term base. I hope you're not going to say they have to find somebody new, but I have, but a lot of that after we do the exposure and response prevention, those longer term bases are really on an as needed thing. And so they'll sort of go out of treatment. They know that I am always here for them if they want to come back, if the dog dies, if there's a divorce, or if they just find that they're having intrusive thoughts again and they're sort of slipping on their skills. And so I know you do a lot of touch-up sessions, some tune-up sessions. I do a lot of tune-up sessions. I work with people on a maintenance schedule. I know you do as well. And so I think it's really helpful to know that if somebody is coming in ready to go, they can get through it really fast in as much as there's not too much complexity and they are ready to hit the gas, and building in some expectations for a longer duration if there is any sort of complexity or hesitation, trouble with motivation. That's very helpful.
I need to actually make a correction about, the length of treatment. If you see a therapist for so long, if you see a therapist for long, years, and, there's no actual progress, you're not moving closer to your goals, maybe that's when it's time to find somebody else. That's just to clarify. If you are having success reaching your goals, moving towards your goals, then even if it's all good.
Thank you. Well, and I think that's another helpful thing for PCPs to know too, is that they might have a patient who has been plugged in with a therapist for a long time. And if they know that, that might be a really interesting question to ask. Are you finding that the work you're doing in therapy is helping? Are you still moving towards something? And if not, maybe offering a different solution. It can be really hard to break up with a therapist. And so building in that expectation, especially if someone has social anxiety or they're afraid they're going to make a mistake, or they're, whatever it is, it can be hard to leave a provider. And I think PCPs experience this firsthand because they see patients throughout the duration of their life and develop really long-term relationships with them. So in thinking about continuity of care, how quickly can a patient typically be seen in West Coast anxiety? What should a PCP tell their patient about wait times? And what can a PCP do to support that patient during the waiting period between referral and then first appointment with us?
We try to get the patients in within a week, 2 or 3. At least I try to do that, right? And I'm confident to say that we all do. What we know is that, that strike while the iron is hot. Usually, if people cannot get in treatment fast enough, they may give up on it, especially if they are a little bit hesitant to engage. So we do our best to get the clients in as soon as possible for an initial evaluation and then treatment they need.
And what would you recommend the PCP does in that in-between period, in between referral and then first appointment with us, if anything?
Probably not much, just, encourage the person to seek treatment, maybe engage in a bit what we call motivational interviewing, helping the person see the discrepancy between living life as they are living it with anxiety and distress and the impact that it has on their lives, right? In other words, does this anxiety, everything that they're experiencing, to what degree does it get in the way of them reaching their life goals and their quality of life? Usually, when we seek treatment, we seek change if things, whatever is going on, hurts bad enough. So helping them see if it hurts bad enough, to see the impact this may produce. Because, we tend to minimize. Life is busy. No, I know it's going to get better. I'll just will my way out of it. I'll just get over it. And if it was that easy, we would not have a job, and we're quite busy at our jobs. So that, I think, would be the most helpful, because, seeing how much something affects us is going to help us get motivated to take the next step to do something about it.
So maybe even at the time of referral, having a little bit of that conversation that helps your patient see just how much pain they're actually in, so that it really increases the probability, that the motivation to reach out and make that referral. I know you have a regular intake that's open. We keep that open for you so that you can move people in and off of your panel. And if you don't end up having availability, we have other providers in the clinic as well. And so if that spot isn't open for whatever reason, they can also always reach out to either me directly for a warm handoff, or they can reach out to our clinical coordinator, and we will find somewhere in the clinic to land their patient pretty quickly.
Absolutely. And another piece that, primary care providers can help is, education. We tend to believe, or people tend to believe, just medication alone is effective. And it's not. That's definitely a misconception. And there is so much research data to support that, encouraging patients to seek additional support to medication management. It is crucial. Speaking of availability, also do the 50 minutes free consultations, for the patients to have a chance to meet with us and, kind of gauge if they feel comfortable enough with us. If, they have any questions, they have an opportunity to ask them before they commit to any treatment.
And we're also open to meeting with the PCP as well to get to know them better, to know about their patient population and whether or not they have any questions for us that we can help and make that bridge more solid. Dr. Aldea, how and when do you communicate back to referring providers about any patient progress? And do you?
The short answer is yes. However, this depends on the patient, on the client. They provide informed consent for me to contact their primary care provider. I'm happy to do that and to communicate. People tend to benefit most, if there is communication between all of their providers. And I like to give updates if I have the patient's consent about, their progress, about what's going on. Sometimes people tell me about the changes they may want or consider in their medication. And, I do not prescribe medication. I cannot speak of that. So, happy to, facilitate that going back to the primary care provider. The primary care provider is the one managing their mental health meds. Also, given clients consent, happy to, touch base with the primary care provider regarding the progress people are making, what else they may be needing. And, the door is open, the other way. If they, they have a meeting with their client, with their patient, and they get any information that may be relevant for their therapy process, I would love to hear it. So, two-way communication, I think, is very important.
Yeah. So in as much as the patient wants that, and in as much as the physician wants that, I think we're always open to collaborating and having that really well-rounded wraparound care for a patient. Okay, so we are a telehealth company. We do all of our sessions in telehealth. I do a few sessions in Seattle in person, and those are usually based on frankly, people having agoraphobia and starting to come out of their houses. And those are a little bit more challenging because I charge travel fees. I'll meet them where they are physically, and we start to do exposure work like that. But by and large, our whole practice is online. So will you share a little bit about getting mental health treatment through telehealth services, who's a good fit and who might not be a good fit for this particular setting?
First, I want to say that mental health care, evidence-based treatment via telehealth is as effective as in person. Maybe some misconceptions out there that it's not as good. Research, very solid research, shows otherwise. And I find it particularly helpful with anxiety disorders because, like, for example, OCD, where, the bulk of the symptoms occurs in the person's personal environment, in their homes. And we have a wonderful opportunity to address what's going on in there versus trying to replicate it in an office. I used to do. So it's really, really powerful. And it really, really works. Actually, I conducted several years ago a study myself. I compared exposure and response prevention for OCD, for veterans with OCD, in person versus during the pandemic via video. And there were no differences between groups in terms of outcome. They both
Right.
demonstrated about 70% improvement in symptoms, which is quite remarkable. Who is less appropriate for care is people who are high risk for self-harm, for suicidal behavior, suicidal gestures. I would recommend the kind of care to be in person. This way, it's easier to manage that kind of symptomatology. This being said, there are other practices, if that is the main concern, are better suited to provide telehealth with that. But I personally do not do that.
Yeah, I am usually quite hesitant to see someone who is just seeking treatment for an eating disorder, as an example, by and large, just because I'm unable to see their entire body, which allows me to really sort of continue to monitor their progress in a way that's helpful.
Oh, yeah. I think that's a very good point, especially, more severe eating disorders. And, those issues also require a team approach, that you have, a physician, nutritionist, and it's hard to coordinate all of those online.
Yeah. Yeah.
On the telehealth.
Yeah. And if someone ends up with us and after doing a thorough assessment, we determine that they are not a great fit for us in this setting, then we do work with some really wonderful providers in the community, and we'll make sure that they have a soft landing there as well. And so, again, speaking to that continuity of care, and in as much as the patient has provided an ROI for us, we can always communicate that back to the PCP just so that there is that we can always be closing the loop.
Absolutely. And specialty care is very important. Unfortunately, general therapy, what you call general therapy for a lot of issues, it's very, very, very effective. However, for certain issues such as eating disorders, anxiety disorders, referring to a specialty clinic is crucial to get the most effective treatment. And with
Right.
long-term benefits, not just, short-term kind of feeling better in the moment.
Dr. Aldea, is there anything else you want to share with the PCPs in the greater Seattle area? Is there any wisdom you'd like to impart, or invitations, or anything that I have missed?
I just want to thank everybody for the work they do. I know it's not easy. Having to address mental health on top of everything else, it is a challenge. Given sometimes, the stress and the expectations that are put nowadays on primary care providers. So we do appreciate working with you, and we want to make your life easier, if at all possible.
Agreed. And to all of the primary care providers that I have already worked with, that I already work with, I am so grateful for you and so honored to be able to be a part of your care team. And so we want to invite more collaboration to let you know that we are here at the West Coast Anxiety Clinic to support your patients and you in any way that you might be needing. And if you have any questions about referring in, I'll provide all of that information for you as well. But thank you for your time and for taking the time to watch this. We know that you're busy, and it means a lot to us, and we're hoping that it will mean a lot to your patients as you continue to provide them amazing care.